And, you know, like if you keep a guy's testosterone level at 550, that's extraordinarily safe and conservative, and it's extremely unlikely that anything bad will happen to that person. It's also extremely likely that nothing good will happen to that person.
All right, welcome back, everybody, for another episode of the Healthspan Podcast, where we talk all things health, hormones, and staying hard to kill. Today, we have a special guest with us, Dr. Andrew Winge, joining us from halfway across the world. Well, maybe it's only about a third of the way across the world, 11 hours in the future. Today we're going to talk about testosterone and minimum effective dose versus maximum tolerable dose. I think it's going to be something interesting to kind of talk about here. Yeah, Dr. Winge is a dual board certified physician, both family medicine, emergency medicine, former Air Force lieutenant colonel, I believe, right? You were in there for, I think I read, was it 17 plus years, something like that?
Long time.
Currently practicing emergency medicine in Abu Dhabi in the UAE. Also has his own men's health clinic and age management practice called Man Medicine. And attached to that, too, lots of great, for anyone who hasn't seen his YouTube channel, lots of good videos and interviews on there, some good deep dives into some topics. I'm a fan. Been on we've seen a lot of your other shows, too, with interviews. So
thanks.
It's great to have you on to chat with you, chat with you about some of this stuff.
Absolutely.
Yeah. Can you, for folks who don't know you, maybe tell us a little bit more too? Fill in some blanks there that I left out. How'd you get into this space, and what got you interested in doing this kind of?
That was a really good intro. I think you hit pretty much everything. I got into men's health out of purely selfish motives. It really was not on my radar. I was interested in my own personal health, obviously, and that started when I can really remember it as a third-year medical student. So I was very young. I was like 21, 22 years old, and doing my first clinical rotations. It was at the National Naval Medical Center in Bethesda, Maryland, where the president goes. And so that was my first inpatient internal medicine rotation. And, that's where, in the inpatient medicine service, it's sick old people. I mean, that's what they take. That's what you do. And that's what internal medicine is. So I started taking care of these, really old people and seeing all the problems that they had, and I just, in the back of my mind, I just kept thinking, like, is this going to be me? Is this inevitable? Am I going to end up like this? And like, I don't know what I need to do, but I've got to figure this out so I don't end up sitting here in bed in a diaper and having a catheter and a feeding tube, at the age of 75, because that's not where I see myself going. Like I was an athlete in college. I was, really big on physical fitness, and I just could not imagine going down that road. So I always had this interest in longevity and in health, but just mainly for myself, for my family members and, close friends and things like that. But I started feeling off in my mid-30s, and it was after my emergency medicine residency. And I attributed it to the fact that I'm working really long hours. I'm an Air Force officer, we're deploying, but something wasn't quite right. Like there was the classic brain fog that guys complain about, and fatigue. And it didn't matter if I, took 2 weeks of leave and got caught up on sleep. Like I just was not feeling well. And I'm kind of embarrassed in hindsight to say this, but I just never put two and two together that I could have low testosterone. And I should have known better, because I was born with bilateral cryptorchidism, which is, for the listeners who don't know what that is, it's bilateral undescended testicles. It happens, it's a congenital thing in the third trimester in male fetus. The testicles are up in the abdomen and the pelvis, and they're supposed to come down and descend into the scrotum before you're born. And that's super important for them to develop normally, for you to have normal sperm counts. And it turns out for you to also have normal endocrine function, later in life. So I learned about that condition in medical school, and so I always knew that I would have fertility issues. I didn't have kids at the time, but I was always like, I'll probably have low sperm counts. And sure enough, I did. But we never really learned that can also cause low testosterone later in life. And so again, here I am, 35, 36 years old, just not feeling really good. And my diet is pretty good. My training, I'm working a lot, but I was just trying to run through the checklist, and I had labs done, and of course they were perfectly normal. And it wasn't until one of my buddies who was a urologist was like, "Hey, dummy, why don't you check your testosterone levels?" And of course they were rock bottom low, and my LH and FSH were high actually. So I had primary hypogonadism, And so, long story short, I kind of dove into this before I started on testosterone. I dove into the subject because I wanted to learn a little bit about it. I was like, this sounds like a really good deal. And yeah, long story short, started initially on, like most guys do, once a week injectable testosterone cypionate. And again, I always say I'm fully willing to admit it could have been a placebo effect, but within a few days of that injection, it's like the clouds parted. Like I felt so much better. That fog in my brain cleared, and it was just, I was off to the races. I was like, this is how I remember feeling when I was in college. This is how I remember feeling like even in my, my late 20s even. And so it was a remarkable turnaround for me. And that at that point I was hooked. Like, okay, like I need to learn about this. I need to learn everything I can possibly learn about this. So not just for myself, but like I want to incorporate this into my medical practice. Like this stuff is magic, So I just devoured every CME course and every certification that I could get for a number of years, and the rest, I guess, is history. So I'm a huge advocate of testosterone for men. It also as adjuncts for treating medical conditions like type 2 diabetes, obesity, et cetera, these sort of off-label indications. I say this to my residents too, because I teach medical students and residents, is, when somebody comes to you with a problem, ideally you want to have all the tools in your toolbox. And so, I'm a Western trained MD, right? So I use pharmacological interventions, I have lifestyle interventions. But why would we also not want to have in our quiver, in our toolbox, why would we not also want to have, especially bioidentical hormones? So testosterone, thyroid, et cetera. There's a lot of use cases for hormones beyond just treating low levels. So I incorporate that into my practice, as well. But I guess that's kind of a long-winded answer of how I got
awesome.
into this space. I find it super interesting. Testosterone changes lives. It really does. And this may sound a little crazy, but I feel like I save more lives in my TRT practice than I do in the emergency department. In the emergency department, I put Band-Aids on things for people. I pull them off they're trying to run off the cliff, and I reach over and I pull them off the cliff and I bring them back, and then they dust themselves off and they try to run off the cliff again the next month, and I pull them back. So and then, we rinse and repeat that. But really with TRT, I've got guys that just radically change the trajectory of their health span, where they change their destiny essentially. And they get to the point where they don't need me anymore. Especially they don't need me in my hospital practice for sure, unless they get hit, in a traumatic accident or something like that. And that, to me, that feels really good. I'm sure you can vouch for this too. I mean, I've saved so many marriages and relationships with testosterone, both for men and for women. So it's super rewarding. Like I really like this type of practice. I still like, I'm a bit of
good medicine. Get to actually spend
it does
some
feel
time
good,
with
right?
people and get to know them. And it's great.
And, in my hospital practice, I spend all day putting people on medicine. But it turns out in my HRT practice, a lot of what I do is end up taking guys off of medicine, which is even better. It's way better.
I always say that too. It's one of my favorite things to deprescribe some meds.
It's amazing.
Hey, do I need to be on this pill for life?
Nope.
Maybe not. If you want to do some work, let's get it done.
If you want to do some work, exactly. Let's get you off of these antihypertensive medications. You're on 3 different blood pressure medicines. Okay. Yeah. Maybe I can get you down to 1. Maybe I can get you to 0. Let's figure it out. So it's super, super rewarding.
Yeah.
I know you feel the same way.
Oh yeah, no, for sure. The whole time I'm sitting here nodding, you hit a lot of really good points already. Yep. And one of them too, you said, your personal experience with testosterone. I think that's a hugely important thing, because a lot of people who are going to see their primary care doctor or even the urologist, if that doctor, nurse practitioner, PA, whoever the prescriber might be, doesn't have personal experience with it, your chances are your experience with them is not going to be great. They're just not going to know enough about it. They're not going to have enough buy-in or knowledge, and you're going to get some half-baked plan at best. It might just blow you off completely.
Well,
Hey, this is crazy.
so that's
talk,
the
you know?
most likely thing, right? Yeah, they'll just be like, you know what, I don't do that. Let me refer you to an endocrinologist. And then, again, I'm not going to bash endocrinologists. They're brilliant people, but you'll go to an endocrinologist, and what will they do? They'll take out their playbook, which is the Endocrine Society, like 2018 guidelines, which we'll get to our,
Right.
topic
Yeah,
of the day.
it dovetails in
But
there
they
real
will
nice.
follow that. They'll follow that cookbook like it's holy scripture, and you may or may not get the benefits that you're looking for with
Yeah.
that. You probably won't.
Right.
To be honest,
Right.
it's just not a priority for them.
No. Yeah, they're dealing with a lot of. If your diabetes is out of control, that's
Yes.
the guy you want, for sure.
Yeah, exactly. And that's why I don't like it when people bash their primaries and even bash endocrinologists about testosterone. I'm like, listen, it's you have to take some responsibility here. You just went to the wrong specialist, you don't send. I always say you don't send your grandpa to the gynecologist, right? Well, why not? Well, they're gynecologists or doctors, but they're not.
You can probably
specialized in
figure it out a little bit. They have some knowledge.
They can do some
They're
basics,
pinched,
right?
do
They
something.
can exactly. So why would you, if you're a male with low testosterone, like why would you go to your average family doctor, internist? Even endocrinologists, I have to caveat that because there are some really good ones out there that really get this stuff. But many of them, like you said, they're really busy with. When I did my endocrine rotations, I'm sure you can probably vouch for the same thing. I spent 95% of my time on complex diabetic cases, weird like neuroendocrine tumor conditions, and thyroid cancers. There was very little. If they're just testosterone therapy is just sort of an afterthought for them. They don't really. They're just not that interested in it. I don't think it pays the bills, quite honestly.
Oh, sure.
For them.
Well, just
you know.
Western medicine in general for wellness care outside of sick care is just not. It's not geared for
great.
it. We don't have enough time.
It's
I
not
mean,
great.
a visit would have been over already at your primary care. This talk we just had here.
For sure.
Boom, that's it. It's
For
time
sure.
to move on to the next. We don't have any time
Yeah.
to
I had
dig into
15
it at
minutes,
all.
and as a family doctor, I had 20 minutes if I was lucky per patient. And I don't care how good you are, you can't give good care in 15 or
Right.
20 minutes. You just
Yeah.
can't do it.
Yeah, in case anyone's
My initial
wondering,
intakes
that's
are
just-
2 hours.
right.
At least.
No kidding.
Yeah.
Yeah, for people who are wondering, it's equally stressful for the provider on the other end, knowing they only have that 15 minutes and they want to get all this stuff out and they can't. They don't have the time to do it. It's just like,
Well,
man.
I spent the whole time, in my clinic thinking like, I need, when am I going to get home to my family? Am I going to make it home to dinner tonight? I still have all these charts to do. And, it's like, you're not present. You're not focused. You're not listening to the patient.
Yeah, it's tough. It's
So,
tough.
yeah.
It's interesting too. So you're saying, one of the things that made you want to get into this kind of medicine is seeing all the, all the sick people and how can you prevent them from getting there. And yeah, it's the same thing. You'd see that too. Like, man, if you could get ahead of that and prevent all these people from showing up in the emergency room or spending a lengthy time in the hospital. But also, and you probably noticed this too, some people who come in strong. So you talked about someone, maybe they come in with a trauma. It's not because of something their own doing, but people who show up strong, they end up leaving. Right? They come in strong, you leave strong.
100%,
Or if you don't come in
100%.
strong, maybe you don't leave at all. Or you go to rehab and you get, you get an infection there and that festers and it's all downhill. So yeah, people who come in strong, they really building that resiliency. It's not all about, muscles and erections. You come in, you build that resilience. You're ready for the event.
No.
You have to spend some time in the hospital. You actually make it out.
And this is the thing I think the general public doesn't really think about this stuff, but those of us, especially if you've done urgent care, emergency medicine, you see what happens to people out there. It's some bad stuff on the streets, and then, as an elderly person too, I mean, they get really serious infections, and when they get sick, they get really sick. Yeah. So my guys I know they're tired of me saying this, but muscle tissue, especially muscle tissue, if you can build up as much as you can before you turn 50, that is it's like money in the bank. It's like Bitcoin in the bank, honestly.
Oh yeah. Yeah. I call it metabolic currency, right?
Return. It totally is. If you have, if you go into a critical illness or injury, let's say you're 65 years old and you've got 20 pounds of spare muscle tissue that you've accumulated in the prior years of your life, that really can make it'll make the difference between you living or dying. It also makes a big difference between you getting to go home once your critical illness is addressed or having to go to a nursing home or rehab center. And trust me, you don't want to go to a rehab center unless you're very wealthy. You don't want to go to these low cost rehab centers are terrible. So most of the people, these elderly folks, they go to these rehab centers, and then they come back dying of urinary tract infections. They get bed sores. It's a nightmare. So you just
for sure.
You want no part of honestly, the modern medical system. You want to avoid at all costs. And there's only one way to do that, and that you've got to get as healthy as you possibly can. And especially if you're under the age of 50, everything gets tougher after 50. Like we were talking about offline, everything gets tougher, even if you do everything right. So, if you just cannot go into age 50, you cannot be 300 pounds at 50 years old. Like, pardon my language, but you're fucked. If you don't fix that, you are.
It's an emergency. It really is. People
it really is.
A little bit of weight.
It is.
No, it's an emergency.
And take this from somebody who literally, I take care of critically ill and injured people all the time. And when you come in at 300 pounds, it is so hard for me to take care of you. If you are really, really sick, just to like roll you over, just to get an IV in you, just to intubate you, everything is tougher. So these are things I think the general public doesn't think about. The medical system, it's the belly of the beast. It really is. And once you're sucked into it, it's very difficult to get out. So, I don't want my guys to ever. I don't want to see them. I don't want to see them in the ER ever.
Yeah, a 300-pound guy. You're happy you finally got him intubated. Then you're like, oh crap, we're going to have to extubate this guy eventually. This is going to be a whole nother job.
Good luck, right?
How long is
good
that
luck.
They're going to wean him off
exactly. And they're going to be on the vent much longer. They're going to get all the complications. Anyway, it's a nightmare. You can ask any ICU doc; will tell you that too. Taking care of obese and metabolically unhealthy people who are really sick it's a bear. And I would much rather, Mike, God forbid, I'd rather have a guy like you. If you come in with a bad pneumonia, like you're going to do fine. You're even if I had to intubate you, you're going to do fine. You'll probably be on the vent for a couple of days and you'll bounce back. But the guys that are sick metabolically and are really have low amounts of muscle mass, high amounts of visceral body fat. That's a combination I see here quite a bit too. People's body composition is really poor here. We don't have the super obese people like back in the States and in the Western world, but there's a lot of sort of skinny fat people, if you get my drift. So there's a lot of people with it's a huge problem. Because they
you lay in a hospital bed and lose 10 or 20 pounds of muscle. You don't have to lose. Exactly. Now you can't stand on your own.
You cannot afford to lose that muscle tissue. So that's when I see that, it's really tragic because all of this stuff I know now, and you do too, that it is preventable. Like heart disease is now optional, in my opinion. In many cases, chronic kidney disease diabetes is definitely optional. And you just have to get it early enough, and you have to get with a provider who kind of understands that mentality. And that's circling back. That's where hormones come into this.
Right. Sometimes people need a little tough love and a little guidance.
They do. They do need some tough love sometimes. Yeah.
Right. Yeah. You have to read the room. You have to read the room.
Exactly.
Yeah.
Exactly.
Yeah. So this, this topic we were kind of throwing around here, kind of, minimum effective dose versus, maximum tolerable dose. Because we see it on both sides, right? We'll see guys come to you from other clinics, or you see them talking online. They're taking this crazy low dose and it's just not effective. And it's not going to work. You wonder, they're taking, 100 milligrams per week for a 220-pound guy. And like, I don't feel any symptom relief. My doc says they won't give me any more. And, middle of the road, total testosterone, no other labs checked. They say, I guess testosterone doesn't work for you. And then on the other side of it, you have guys claiming they need, I have long CAG repeats, so I need 350 milligrams of test a week, and you don't know me. That's what I need. So the truth is probably somewhere in the middle there. What are your kind of general thoughts on that?
Well, the first guy that you mentioned, his doctor is doing what he's been told to do by both the Urological Association and the Endocrine Society guidelines, which is to shoot for a mid-range normal testosterone. Like the AUA, the urology group, they want you between 450 and 600. And if you exceed that, then you probably need to have a dosage reduction because well, they'll argue, oh, you're going to have a stroke, blood clot, heart attack, DVT, PE, et cetera. And the Endocrine Society says essentially the same thing. They want to shoot for like a mid-normal range. And, it's no wonder guys don't feel better because, it's important to recognize this is just in general with guidelines. Guidelines are not holy scripture. They are not, oftentimes they're not as evidence-based as we think. And guidelines are just that, they're guidelines. And guidelines are put out guidelines are not for experts in a subject. Guidelines are made for people who are not experts in a subject to keep them on to give them a framework from which to work and to keep them on a nice, safe, narrow path. And, like if you keep a guy's testosterone level at 550, that's extraordinarily safe and conservative, and it's extremely unlikely that anything bad will happen to that person. It's also extremely likely that nothing good will happen to that person. Right. And you're right, and that's where, like, I heard one of the guys he was actually on the panel that made the Endocrine Society guidelines. He's like, yeah, like something like 40% of men discontinue testosterone therapy within the first year, et cetera. And I'm thinking to myself, well, of course they do. Of course they do, because you don't titrate them to an appropriate level. I don't know what it's like in your practice, but I don't have 40% of men dropping out within the first year on testosterone therapy. I mean, I have like almost 0% dropping out.
Near zero attrition rate. People
once they get started, near zero attrition rate.
You just want to know what
if you look statistically,
I can be doing.
Right, precisely. So, but if you look at the endocrine literature, that's what it'll tell you. And of course they're dropping out. And of course there are these studies out there which show, that, many times there's no benefit in certain areas with testosterone therapy. But if you look at the studies, well, of course they're not getting better. The average T level was like 450, and you took somebody who was 250 and you brought them to 450. And, there might be the outlier out there who gets a good effect from that, but most men require greater doses of testosterone. And it's also important. There's so many parts to this. Physicians make this mistake, and I think the lay public does as well, that if there's a recommendation in a guideline, they assume that it's coming from good evidence-based literature. Like there must be a reason why they recommend 450 to 600, for the urology guidelines. And, if you dig into that, the truth is this is what's called consensus or expert opinion, which is the lowest level of evidence. So basically they just said, well, they made it up. I mean, they made up that number. This panel that put together these guidelines said, well, this sounds reasonable, but it's not based on a lick of actual literature. There isn't a single study out there that shows that a level of 450 to 600, for example, is optimal. None, zero. And so there's no head-to-head comparison. Those of us that have been prescribing testosterone for a long time, we know very clearly there's definitely a difference between guys who are at the high end of the normal range and honestly many times have to be well beyond the normal range. Those guys, that's where the clinical benefit lies, and not just in some of the feel-good effects and the mood changes and stuff like that, but in parameters like insulin sensitivity, in muscle tissue hypertrophy, in libido and sexual function. The real sweet spot for many men is way north of 450 to 600. But if you stick to the endocrine guidelines or the urology guidelines, you never see those guys. All you see is treatment failures. You see a small group of guys that do well, and then the rest are treatment failures. And if they would just loosen up a little bit and allow their guys to be a little bit higher, all of a sudden they would see what you and I see every day, which is these like really impressive turnarounds in terms of symptoms and quality of life. But they're constrained by these guidelines. And guidelines are just that. They're just guidelines. And they're guidelines for people who are not experts. I always say, like ACLS, the Advanced Cardiac Life Support guidelines, every couple of years, I have to take a CPR class, to keep my job. Like I'm a board certified emergency doctor. Right. I have to take ACLS, which it teaches you how to run code. I run ACLS codes every single day, almost. Not quite, but sometimes 2 or 3 times a day. So ACLS is not for emergency physicians. It's not for cardiologists. The trauma, the ATLS course, Advanced Trauma Life Support, they make trauma surgeons take it. ATLS is not for trauma surgeons. ATLS is for pediatricians who just happen to stop and have an adult trauma thrown in their lap.
Right. It's for someone who's walking by and they were the first one there.
Yeah, it's for family.
Right?
It's for the family practice doctor working in urgent care out in a rural place who gets a gunshot wound out in their parking lot. That's ATLS. It's not for me. It's not for trauma surgeons or general surgeons in general. So that's how I look at these endocrine guidelines. Like these are for the family doctor who twice a year gets a guy with low T and is like, oh crap, well, what do I do with this? Let me look at these. Okay, this is what I do. It's not for people who have expertise in a field. So, the guidelines are the guidelines, and unfortunately, we get held to that standard sometimes. Medical boards will waive those guidelines, but I have a round file over there, and that's where the guidelines go in my office.
It's a shame because none of these address. There's no talk about free testosterone. There's no talk about SHBG going up in older men, so that that stable testosterone your primary care doctor keeps telling you about is really not really not that important.
No.
But there is research showing that it is, right. Symptom resolution is more correlated with free testosterone instead of total.
That's right.
And you're lucky if anyone ever checks you're free if all you do is go to your primary care doctor.
Precisely. Well, and this is what it gets back to that that level of you and I know this because we are quote experts in this. But your family doctor, I don't expect them to know that, and that's okay. But you're right. The guidelines, there's glaring holes in the guidelines, and the fact of the matter is. Again, it sounds good, right? Like we want to replace you back to what you were when you were 25. We want to keep you in a healthy physiologic range. Well, that sounds good on paper, but the fact of the matter is, a male that naturally can produce a testosterone level of 800 is a very different animal than the average male that you and I see who comes in, even if they're at the same age, whose levels are 250 or 300. That the guy who's 800 naturally, that he's on a different planet metabolically. That guy, everything works well for that guy. Testosterone levels are a surrogate in many cases of overall health. So it's true, like that guy at 800 feels amazing because everything else is working well in his body. He's probably young. The same guy, the guy with 250, we might bring him up to 800 and not see much of a clinical effect. Well, why is that? Well, this is a diseased individual. Like these two guys are not the same. There's so many reasons why. I mean, we could have a whole nother podcast on why men require, and oftentimes they require supraphysiologic testosterone levels. And then, that sick, metabolically unhealthy guy who's full of microplastics, who's saturated with endocrine disrupting compounds, and it doesn't make sense that he is going to have the same clinical response, to a level of 800 as this otherwise pristine, metabolically healthy guy. It just, they're not the same. Insulin, like we don't do this in other parts of medicine, right? So we don't dose insulin, for example. This is probably the best example, based off of your levels. You and I, healthy middle-aged men, we probably make about 40 units our pancreas makes 40 units of insulin every 24 hours, give or take, depending on our diets and, if we go on a binge or something like that. But, if I have a fat, insulin-resistant, inflamed diabetic, I don't dose his insulin based off of the goal of keeping his insulin level within the normal range of a, quote, healthy male. I dose his insulin to, one, treat signs and symptoms of hyperglycemia, so polyuria, polydipsia, and to treat and avoid the complications of type 2 diabetes. And the dose is the dose, right? Whatever it takes to get there. You and I make 40 units of insulin every 24 hours, give or take. Well, I have plenty of guys, especially back when I did this more full time. They're they're taking 100 to 150 units of Lantus, for example, long-acting insulin, every single night, and then they're dosing regular insulin on a sliding scale. They're a couple hundred units of insulin per day. So, what would happen to them if I said, listen, we need to keep your insulin levels in the normal, we want to replace you to the normal physiologic range? No, they're going to run around with sugars of 500, right? They're going to go to the ER, and because their sugars are 500, or they're going to go into DKA, they're going to have all kinds of problems. So, why are we doing this? Why are we taking that same mentality and we're applying it both to testosterone, also, and in many cases to thyroid as well? You've got a diseased individual. They have anabolic resistance. Anabolic resistance is a well-known phenomenon. You've got an androgen receptor that perhaps is compromised with endocrine disrupting compounds. You will require a greater concentration of free testosterone to get the same effect as you would if you were otherwise, completely healthy and lean and, lived in a pristine environment, 200 years ago, for example. So we shouldn't be afraid to use pharmacological doses of testosterone. You're treating a medical condition. So you have left the realm of physiological replacement, in my opinion, with many of these guys, especially if they're diabetic and they have all these other issues. We're in the realm of pharmacology. And so, you give the appropriate dose of the medication to treat the condition that you want to treat. And so with testosterone, that oftentimes, and probably 8 to 9 times out of 10, will take you above these established reference ranges. So there's no correlation between these normal reference ranges and then what's optimal for somebody, or what's required for somebody who is in a diseased state. They're not the same. But physicians, even endocrinologists, like they think that those are the same thing, and they're not. It's not the same
anytime,
thing.
Anyone who sees that out of range lab on a report with, it's in red or has an H next to it for high, everyone gets all upset and worked up. Like, everything has to be in context here. And, and in TRT, we're not talking about absurdly high numbers. We're not talking about a total T of 3,000. Some guy who's blasting all kinds of steroids or something. It's not what we're talking about. And I have... You talked about like anabolic, resistance, or how cell sensitivity. I was half kidding earlier about the CAG repeats, because guys like to say that, but there's a little something to it for sure. It's not the huge difference they think it is. I think some of the studies show it's maybe like a 10 or 20% difference.
Right.
But if you're talking about someone who's going to undertreat you in the first place, that could end up being a big deal. So someone needs to push it to feel better.
You always have outliers, right? Everything in life, everything's a bell curve. And you're going to have people on the left side of that bell curve who don't respond to typical levels. The physiology of testosterone is so interesting. I geek out on it a lot, but there's so much that happens from the time that testosterone ester enters your bloodstream to when you finally get the final end clinical effect of one of its many downstream metabolites. And there are so many things that can go wrong along that pathway that it just will make your head spin. And if you have a diseased individual, that's where you need to have, oftentimes you just need to have higher levels to drive those reactions forward. If you have normal physiologic levels, if you put in normal physiologic levels, what you get out on the other end of that very long pipeline, you might be putting a garden hose in, but what you get out at the very end of that pipe is just a little drip in terms of the clinical effect.
I think your insulin.
So you need to hook the fire hose up.
Perfect. But insulin parallel, you need to hook. Because everyone seems to understand insulin resistance and glucose intolerance. So it really is pretty close.
No endocrinologist, and when I was a resident, none of them have ever asked me, well, you're treating a diabetic. What are their insulin levels? Have you measured their insulin levels? Mm-hmm. No, I'm measuring their blood sugar. I'm measuring their hemoglobin A1C. I'm screening them for neuropathy and retinopathy and all these sort of things. And so we need to change that paradigm a little bit. And it's, we'll get there. We'll get there eventually, I think. The Traverse study was pretty helpful because it did quiet down some of the noise from people who are raising concerns about testosterone, but it hasn't quieted the noise for those of us that advocate in some cases for higher super physiologic levels, because they didn't look at those levels. Right. And
we do have some that
so
did,
we're never
right.
Some did, yeah. There's definitely some. The Bayesian studies, up to 600 milligrams, but they're short-lived, and it's easy to poke holes in some of those studies. But
20,
you're right,
24 weeks max kind of thing.
And there was essentially no deleterious effects to up to 600 milligrams of testosterone. I'm not advocating for that much. That's clearly way beyond.
If we're going to talk about a safety, like maybe a range, like you're not going to be prescribing 600, so. And the Traverse trial used very low doses and not the stuff we normally prescribe anyway. So there's that problem, right? Using gel. But to see guys in those studies, I think one of them had, there was like a 125 milligram group, a 300 milligram group, a 600 milligram group. Yep. Then there was cousin studies, one with young guys, one with older guys.
Yep.
And really, until they got to the 600 group, I think HDL came down 6 or 8 points. Nothing else really bad happened. I think in the older group, maybe their their hematocrit was a little bit higher. They're like, oh, this is a little worrying. They got a little bit high, but we know, we don't worry about that so much anyway. So
but the dropout rate was very low.
High.
Mm-hmm. Yeah, all of the bad things that people thought would happen in the short run didn't seem to happen at all in those studies. What's interesting about testosterone, the anabolic effects, we should probably break this up also into terms of, depending on the clinical effect that you're looking for, that will also determine what sort of levels and what sort of doses you're looking at. So, the anabolic effects of testosterone just go up and up and up with dose. Eventually there is a saturation point, right? Everything will saturate at some point, but there's a reason why bodybuilders take 1 to 2 grams of testosterone, per week, is because
more drugs have more effect.
More drugs is more muscle, right? So the ceiling, in terms of the anabolic effects, is very, very, very high. So if you have a potentially, like if you have somebody who's got a wasting disease, who's cachectic, or maybe like a burn patient is such a great example. Burns are, if anyone's ever worked in a burn unit, they'll tell you, it's a nightmare. These guys and gals are hypercatabolic. They burn through muscle tissue like you would not believe. And that's actually where oxandrolone historically has gotten a lot of use, is in burn units. So, if you're dealing with that's one extreme. Are you going to give them physiologic doses of testosterone? No. Like if I'm your burn doctor, like I'm probably going to give you closer to a bodybuilding dose of testosterone potentially to help mitigate some of that muscle loss. So with testosterone, with the dose, if you're looking for primarily an anabolic and a muscle tissue effect, that's the higher doses are where it's at. Those the studies you mentioned with the high doses, the 300 and the 600 milligram doses, there seemed to be a linear correlation with sexual function too. So more nocturnal erections, certainly a higher libido. So if if that's the issue, then these 450 to 600 range, if that's the condition you're looking to treat the most, that's probably not sufficient. The data would suggest there's benefit at that higher range. So if it's a mood or
even just that anabolic part though too, and we were talking about older guys or older people in general earlier, what's one of the biggest things? You don't want to be, you don't want to lose muscle mass.
Precisely.
It's terrible.
Well, and this is with type 2 diabetes. Absolutely. So, and that's the other indication too, maybe to push that dose, to a higher level. The other indication is people with type 2 diabetes, who have insulin resistance. Mm-hmm. The best thing you can do, other than losing body fat, to get your blood sugar under control, is to increase the reservoir, the gas tank for your glucose, which is muscle tissue. Mm-hmm. So those are people that I have no problem, as long as everything else is in order, of taking those men beyond, the 900 arbitrary upper limits of normal. Because what do I see? I see better insulin sensitivity. I see them getting more muscle tissue. They lose much more visceral body fat at those higher levels. And every single health parameter seems to get better. So we should not let a number on a piece of paper with a red H scare us. we need to step back and just basic medicine. Look and listen to your patient. Are they your blood pressure is getting better? Look at this. Your lipids are better. Your fasting insulin levels are way down. Everything, your triglycerides, everything is getting better. So why am I worried that your free testosterone is 35?
Right.
For example,
You're also you're less depressed. You're less anxious. You're
exactly
more motivated.
Your sex
to
life
life.
is back on track. Yeah. If every other health parameter is getting better, why am I worried? I'm still I monitor you closely. I monitor all my patients, even the ones that are not on testosterone. I watch them like a hawk. But I don't know. I'm just not seeing, and those of us who have been doing this for a long time and are not afraid to take those doses above the super physiologic level within reason, we're just not seeing these negative effects that people think that some people are not as well.
The body count isn't there that
it's just not there.
Talks about.
No,
right?
it's just not there. In fact, it's like universally beneficial almost. So now there are guys, we should kind of step this back a little bit. We'll talk about, the guys that say, well, I need 350 a week, 400 milligrams. It's like, there comes a point, where all of these pathways and receptors are saturated. And, just like any diagnosis in medicine, if the therapy that you're using is not working and you're using it properly and you've taken it to its reasonable conclusion and you're still you're not moving the needle, you need to step back and rethink your diagnosis. Maybe there's something else going on. And, it's thyroid, it's sleep apnea. It's,
sure. Yeah. If you don't have your other lifestyle things dialed in.
Yeah.
I tell people this stuff won't even work unless you're doing that stuff, just to
Precisely.
give them an expectation. Like if you don't plan on getting some good exercise, including resistance training and eating right and losing some body fat and sleeping well, you're going to be super disappointed in testosterone. But if you're going to do those things, it's going to work out pretty good.
This is where expectation management comes in, right? For a brand new guy, your guys are probably like mine. They have spent a lot of time researching. They've been on the internet. They've been on the forums. And so, sometimes they think that testosterone is going to be the magic bullet that's going to, it's going to turn my life around. It's going to change everything. And it's, sometimes it is. Sometimes it is, but you're absolutely right. Many times it's just, what it does is it sets the stage for you to now do some hard work and to actually get some reward from your hard work. Whereas before, the hard work really wasn't paying off for you, but you still got to do the hard work. If you just sit there like a couch potato,
you get that guy who shows up, he's already doing all that work, and you pour this on there.
It's amazing. Yeah, I've got a couple guys, I won't say their names, but I'm just so proud of them, man, in my panel. Like I have guys that lost 50 to 100 pounds, and they do it in a year, and they're doing it without Ozempic and these sorts of things, but they take this stuff seriously. And when you do these things correctly, when you correct the hormonal deficiencies and you get people up to adequate levels, when they do the nutrition, when they do the training, and they really take this stuff to heart, I know you've seen it, man, it's like magic. It's just like magic for these guys. But I take care of the hormone part and I advise them on their nutrition and diet, but they still have to execute. If you're not willing to execute,
that's
if you're still drinking,
I can't follow you around.
I can't help you.
And follow you around and what you're eating.
No.
I tell them I can do it. It's going to cost you, $800,000 a year. I'll follow you around.
Exactly. I say the same thing, right?
It's not going to be cheap.
I say the same thing. Yeah. You want me to look through your cupboards in your kitchen? I'll do it.
So you're talking about this, this line too. So, a lot of times we talk in terms of, free testosterone instead of total. So I kind of said some, and again, nothing's written in stone or anything, but I find most guys feel their best between 20 and 40 nanograms per deciliter.
Yeah, I think that's about right.
If you're above 40 nanograms per deciliter and you're telling me you're not feeling good still, there's probably something else going on because you're running.
Well, you're right. The higher you go and you're not seeing a clinical effect, you just listen to that. If you're an experienced clinician, just that voice in your head, what am I missing here? What am I missing here? And this is how medicine is practiced, right? In the emergency department, if I've got somebody in shock, and they're not responding to IV fluids like I think they should, then I need to step back and think, what am I missing, right? What am I missing here? Mm-hmm. Are they bleeding? Are they adrenally insufficient? What's causing this low blood pressure? If I'm pretty sure I'm giving you enough fluids, you're not turning around. It's just like anything, you've got high blood pressure and I've got you on 3 different drugs and you're still not under control. Okay, so let's step back and what else am I missing here? And that's where it really helps to just be an experienced clinician and have experience outside of TRT. That's a different subject, but I encourage young physicians and mid-levels oftentimes not to go directly into TRT practices or hormone practices right out of training. There's advantages to practicing regular real medicine before you go into this sort of thing, just because you can have that big picture view of what's going on.
Oh, for sure. Yeah, because it's the whole it's the whole picture. People come to you with other health problems, and how does it mix with this, and they ask you for advice on those things too, right? Because even if they are
all the time.
I have a lot of guys telling me, and ladies too, like, hey, you spent more time telling me about this than my primary care doctor or my specialist. Or, you explain my no one's ever gone through my lab like that. So it's it is nice to have that background for sure, without a doubt.
For sure. Well, that's why it's I tell people to get, when you go through an insurance-based system, you're just not going to have somebody sit down with you and spend the time that you need. I mean, this stuff it's not rocket surgery, but it also is not, there's some complexity to it. And some people are very complicated. They come with a lot of medical problems. There's the easy ones are the 41-year-old guy who's on no meds, has got no other issues. But, I get grandpa every now and then, and grandpa has prostate cancer and heart failure and type 2 diabetes and stage 3 kidney disease. And now I have to now I have to put my thinking cap on and, and address it. And I'll be honest, it helps that I've taken care of hundreds and not hundreds of thousands, but thousands of similar grandpas over the years in other contexts. So it's a good thing. Yeah. But, go ahead.
No, I was going to say, but yeah, you're totally right. Yeah, the big rocks still totally apply, right? You get someone in there, you get them more healthy, you get them less fat, remove some adiposity, correct some hormones, and no matter where they are in that spectrum, the healthiest guy or the sickest guy, it's all gonna make it better.
That's the low-hanging fruit. It's the low-hanging fruit, And again, if not to bash endocrinologists and urologists, but I don't know any. I know a lot of endocrinologists. I don't know any of them who are in shape. None. They just don't. It's not their knowledge base. It's not their wheelhouse to help with the nutrition and the training and to really emphasize some of that stuff. They're very good at what they do, but they're not going to be able to give you good lifestyle nutrition advice. Can you imagine going to your endocrinologist? They're everywhere. That's the norm. I mean, there's studies on this too.
It doesn't mean they don't know anything, but
no, they know a lot.
It's easier to trust the guy who's taking care of himself, I think.
I have some fantastic cardiologists that I work with. I hope they're not watching this, but they're really amazing guys. But 3 out of the 7 are morbidly obese, guys. And so that's, that gets back to my initial experience in medicine is, I know these cardiologists and these endocrinologists, they see these sick, frail, elderly people. I just sort of wonder in my head, has the light bulb gone off? That's going to be you.
Yeah. They're so busy and distracted.
They're so busy.
Not realizing that they're at risk.
Doctor, heal thyself, right? Doctor, heal thyself. And,
that could be a problem.
That's going to be you. And I don't want that to be you. I certainly don't want it to be me. But that starts way early. You got to get on that. You got to get on this train early, in my opinion. The earlier, the better.
For sure.
Yeah.
I wanted to hit, I know we're getting about an hour here. Do you have a couple more minutes to hit an estrogen topic real quick?
I'm off today, man. We can go as long as you need to.
You might? All right. I don't want to take advantage.
No, we're good.
Cool.
I'm off. Sunday, I'm off.
All right, nice. Well, that off time's valuable though too. So I appreciate you. But so And let me know, I don't know if you see the same thing or, what you've seen in research about this too, or just, clinically also. But, the estrogen thing is such a hot topic in testosterone. Everyone wants to treat it. Everyone wants to block it. I think it's so much simpler. I mean, I see kind of four kind of classes of guys. I think we're seeing like, people who are in good shape and have a good body composition, and they're non-obese. And they probably have, they're lower aromatizers, probably, right? They probably just don't even have that happening at all. Then you probably have guys who are in shape and not obese, and they're high aromatizers, but it probably doesn't matter because the research I'm seeing on this shows that maybe that's, like 10 or 20% more. And that's just clinically insignificant. And it even shows like these guys don't get symptoms. So it's not a problem. So, people who say, hey, that's me, I have this, I have this genetic predisposition for that. It's probably not an issue. Then you have obese guys who are probably, again, they're probably low aromatizers, probably not a problem, maybe a little bit. And then you have guys who are obese who probably have this, they're high aromatizers, and now they're maybe making twice as much estradiol, twice as much estrogen. And those are the guys who are probably getting some symptoms. But I think all these roads lead to dose your testosterone appropriately and get less fat. Right, lose some adiposity, and all these questions go away. There's no, we need this blocker.
There's very few
supplement
very few chronic medical conditions that don't get better or completely resolve with 15% body fat or less. Like just
so true.
Name me a chronic disease that doesn't get better with your 15% or less. Right.
Yeah, that's what makes all these GLP meds such a huge thing, right? I mean, you're talking about something that
if they can keep their muscle tissue, if they do them correctly.
Right.
Yeah,
exactly,
absolutely. But the aromatization thing, testosterone, its conversion to estradiol, this as well as I do, is that's where a huge portion of the benefits of testosterone come from. Estradiol. It comes from estradiol. I take oral estradiol. I've talked about this.
I've heard you talk about it. I think that's super.
And I don't take a little bit. I take a lot. Okay, I take 4 milligrams oral a day, and I do that for my lipid issues. I'm not saying that other people have to do that. It works extremely well for me. I feel amazing. I have no gynecomastia. I'm still I'm lean. I'm healthy. I feel fantastic. My serum estradiol levels are well over 100. Well over 100.
You're not crying at dog food commercials or watching a lot of Bravo watching a lot of Bravo TV or shoe shopping.
No, Hallmark Channel.
Thank
God they don't have that here. But anyway, estradiol is well over 100. Well over 100. Yeah. In fact, I'm due for labs here, so I'll make a little video about it when I have it done.
I checked mine not too long ago just as a teaching point for a video I was doing. I don't usually check it. I got an ultra sensitive one, spent the $40 and got the thing.
I don't routinely.
So mine was 104 picograms per milliliter.
Oh, yeah.
So I didn't know if I was supposed to call 911 or go straight to the ER or what.
Oh my God.
It's saying I feel fine. I don't feel,
You're going to get a blood clot.
Yeah. I didn't have to go to Turkey for gyno surgery. It's all right. It's all okay.
But yeah, so again, estradiol is that we could do a whole podcast on that, but I like to go back to just basic physiology. When you have let's talk about the obese guy with high estradiol. So as opposed to the other guys, why does he have high? Why would his body use the resources that it has, the limited amount of testosterone that guy is making, in order to elevate his serum estrogen? Of all the things that it could do in response to his obesity and his metabolic dysfunction, why would it pour fuel on the fire, is what people think? Why would it make this substance that's making him feel worse? Well, the fact is it's not. It's making this estradiol it's trying to protect itself. All right, it's trying to protect his body from the inflammatory and toxic adipokines, which are these hormones that are made by visceral body fat, which in levels that you find in obese people are universally bad. There's only 2 that I'm aware of. There's several hundred adipokines, and there's only 2, which is leptin and adiponectin, that at higher levels have actual health benefits. All the rest are deleterious. They're bad for your blood vessels. They're bad for your brain. They're bad for your heart. They do all sorts of things. And guess what's good for your brain? Guess what's good for your heart? Guess what's good for your blood vessels? Is estradiol. So, the estradiol is not, they're throwing the baby out with the bathwater, so to speak. And they're blaming, they feel bad, they look bad, their labs are terrible, and then they get this estradiol number that has a red H by it, and they're just saying, well, that must be the reason. That must be the reason I'm feeling bad, and it's not. That's not the reason. Now, estradiol is involved in some of these pathways, right? So the guys that have fluid retention, for example, if you do it the dummy way and you give them an AI, some of that fluid retention gets better. But the root cause is not estradiol. The root cause is the renin-angiotensin-aldosterone system. It's transient sensitivity to antidiuretic hormone, which goes away if you just wait. Or if you can put them on a low dose ACE inhibitor or an ARB, that treats the root cause issue. And then you can leave the estradiol where it is. So estradiol is, when the guys have these quote high E2 symptoms, which they're not high from high E2. The solution is not to lower the E2. The solution is, how do I fix your symptoms while allowing you to keep the benefits of a high E2 level? Because these high E2 levels are beneficial, especially from a cardiovascular standpoint. So how do I fix? Okay, you've got water retention on TRT. Okay, let's address that. But how do I do that without taking away this very beneficial hormone? And that's the approach I think that needs to be taken when guys have these quote high E2 symptoms. Is how do I fix your symptoms at the root cause while keeping this very beneficial hormone and where your body clearly wants it to be at this time, right? So that's
there's
how
a modifiable factor here, and it shouldn't be the estradiol; it should be the adiposity. So we get rid of that, and you're fixing not only your symptoms, but you're just getting healthier in general anyway, right?
You're just getting healthier in general.
Yeah.
So the estradiol is a response to the metabolic dysfunction and the poor health. The body is trying its best to compensate for this, abnormal, unhealthy situation. And it's doing it by raising your estradiol level. And there's a lot of ways that we know that, but one of them is, when we give guys metformin, and we know this from breast cancer studies in women, but when you give guys metformin, it down-regulates the aromatase enzyme. Well, why would that happen? Well, you're becoming more insulin sensitive, right? The pro-inflammatory and adverse effects of hyperinsulinemia are getting better. So the body's like, I don't need to have all this extra estradiol around. Your estradiol levels will come down with metformin. So, as a joke, but it's kind of true. Okay, if you think you really need an AI, take metformin. That will make that number look a little bit better. And actually, you might actually have some health benefits from metformin, whereas you get zero health benefits from anastrozole. In fact, there's no upside to anastrozole. It's all downside.
That is part of the problem, though, too, because you're right. Guys they'll get a temporary relief of their symptoms. Like, well, hey, if that wasn't the problem, then why, when I took it, did I feel better? Like,
and then they're on it for life. And that's the problem. It never gets taken away.
Yeah, if you're hungover and you take a Xanax, it's going to make you feel better, but that's not necessarily a good plan either. So.
I've got a buddy who's a good friend from high school who was put on an AI like 15 years ago for some transient BS symptoms that he had within the first 30 days of his TRT regimen, and he still takes it. And I'm like, buddy, what are you doing, man? Like, you don't.
That's crazy.
You didn't need it then, but it's psychologically he's wed to this, and his provider is not that bright, to be honest. And but psychologically now he's like, well, I don't want to. I remember, I had itchy nipples, 15 years ago. I don't want that to happen again. So he's stuck, and I can't. To the best of my ability, I cannot convince him to come off of his AI. So okay.
Yeah. I just saw a Facebook post here too, and I was just about to reply to it before we came on. So I just didn't hit reply on there, but there was a guy. Someone was asking about DIM on there. right? And when
Oh,
someone else
God.
came
Yeah,
out
I
and
get asked
replied
all
and
the
said, "Hey,
time.
I used it for a short period of
Yeah.
time. I got relief from my symptoms, but I was I forget. He said his body fat percentage was like in the 30s, 38% or something."
Yeah.
So he
I
said,
saw the post, actually. I read
"Oh,
it
did you
as
see it?"
well.
Yeah, I had
Yeah.
something
Yeah.
queued
Yeah.
up.
Yeah.
I thought this guy's story was great because he says that he lost the weight and now he doesn't
Right.
need the dim anymore. It's like, exactly, man. That's it. You pulled the right
Amazing.
trigger. And that's it. The problem
Right.
wasn't the
Yeah.
estradiol. It was you need to get that
Yeah.
body fat down, and you did it. And congratulations. That's awesome.
Good for
And
you.
you found
Yeah.
your answer.
Dim keeps
Yeah.
coming back. It just keeps like, I made a video about dim a while ago, and dim is not. It's just not helpful. Dim. The guys don't know this, and nobody talks about it. Dim blocks the androgen receptor. All right? It works like Casodex, which we use it for end stage prostate cancer to block the androgen receptor, and you put dim in a petri dish with cells, and it's you can see it plain as day. It's just like Casodex. It blocks the androgen receptor, so you're potentially blocking the anabolic effects of and the androgenic effects of both testosterone and DHT when you take dim. Now it's weak. It's not it comes from a vegetable, obviously, but like, why would you want to do that? It doesn't make any sense to me. It's not an aromatase inhibitor. Guys think it's an AI. It's a natural AI. It's not. That's not how it works. It works
You're
in
changing the
estrogen
metabolism
metabolism.
more than anything, right?
Yeah, and maybe in women there's a use case. Even in women, I don't think there's a use case for it. There might be female HRT experts that debate me on that. But for men, like, come on, there's just there's no use for dim. But guys, there's no shortage of clinics. One of my buddies was working at a clinic, a brand new clinic, and he said almost like 100% of the men that he sees by these other providers have been put on dim, and it's just like. It's just like they sell it, so they hand it out.
Oh yeah,
it's the new anastrozole for them.
Almost
So
every
it's worthless. It's
every
completely
guy who
worthless.
comes to me who's having some sort of problems, they're really like, "Oh, this is a tough case, so I came to you, and I'm hoping you can help me now." Almost 100% of them are just taking all kinds of extra crap, and it's really just a
Right.
matter of getting them off the
Right.
extra crap, getting them on a reasonable dose of testosterone, dosed appropriately in
I know.
the right frequency.
That's right. That's why I said it's
Talk
not
them into
rocket
taking
surgery.
this other crap and getting some exercise and getting in shape, and all of a sudden it's like,
Yeah.
boom, you're there.
But this is how these clinics, they make a fortune by selling adjuncts. And so there's the base, testosterone is cheap. Nobody's making any money off of testosterone, but the money comes from the peptides and the supplements, things like DIM, and it's the anastrozole. And then, you need a little bit of oxandrolone in there too, of course, right, Mike? You need some nandrolone too. And,
Someone was just telling me someone else I was talking to said that they had a patient come to them and said as they were checking out in their cart for their payment, there was an option to add oxandrolone as an add-on, like add to cart.
Yeah. Online. Yeah. It's like
point of sale item.
It's the buffet, man. We're going to the Men's Health hormone buffet, and let's do that. I mean, there's a very well-known clinic. And I'm not going to name them because I don't want to end up some stupid online spat, but it's very big that prescribes stenozolol, Winstrol, and oxymethylone. They said in some cases, if you qualify, oxymethylone is androl 50. It's like, are you freaking
Where
kidding
the
me?
hell are you getting that from, even? That's interesting.
Well, it's because you can get it. There are compounding pharmacies
Really?
that will
Interesting.
make it. Yeah.
That's
Maybe
amazing.
they know something I don't know, but short of like
Maybe they're anemic.
aplastic anemia, short of like utter bone marrow failure. Like, tell me if and it said the quote was like, if you qualify. I'm like, what are your qualifications to get that drug? I'd love to know what you're doing. So this is where they make their extra money. So guys like you and I that are
Terrible
sticking to
salesman.
the fundamentals, we're terrible salesmen. I always say I'm not a testosterone salesman, but you and I sell the fundamentals. It's not sexy. Like, it's kind of boring. And after a while, guys are like, well, why am I paying for this when I can just go to some cheap HRT clinic? But they don't always appreciate. They think more is better. I'm getting more stuff from my provider, so therefore he must be good. And the fact of the matter is, like, getting less from your provider in terms of pharmacology is probably best. And we stick to the basics because we know what works. Like I could make a lot more money if I started shilling some of these other substances. But, I also need to sleep at night, and I need to look in the mirror and, feel good about what I do every day. So you won't be getting oxandrolone from me in my clinic, and anything like that. So
unless you're a burn patient.
Correct. If you're critically burned,
you can make your case.
I'm gonna hook you up. Trust me,
right.
I will hook you up. But short of that, sorry.
Yeah.
Yeah.
So with the another point on the estrogen too, I think it's interesting. Yes, you hear guys say again, like they think they're a special snowflake. They have this polymorphism. I'm a high high aromatizer. I was looking at some of the data on that, and then it's not super impressive. Again, it's like 10 or 20% difference, and then even in the studies themselves, they say this does not correlate clinically at all. Right, so you go, you're up 10 or 20%. It just doesn't make any kind of a difference. So it's still just kind of silliness.
It doesn't, and it gets back to the fact that like we shouldn't even be measuring this at all.
There's that too.
This is an endocrine and paracrine hormone. There's a really good paper that has made the rounds, and it's I believe the title is Estradiol as a Male Hormone, and it's by 2 MD PhD endocrinologists, and they just they do a really good job of laying out the case for the importance of estrogen in men. And one of their concluding paragraphs, they talk about the intracrine and paracrine nature of estradiol and the fact that what you see in the serum does not correlate with what you see in the tissues.
Exactly.
So, you cannot make clinical judgments based off of serum levels. They're essentially meaningless, and they even... when I went over this paper, like I highlighted it, it says don't check them. It says, you should, and don't check them, and don't make clinical decisions based off of this number, because it's just not, it doesn't reflect what's going on in the tissue. And this is what, I have to harp on this more, but I feel very strongly, I'm very pro estradiol, as you can tell. When you take an AI,
I don't want you to get weepy about it though.
Yeah, well,
then you're going to lose your point.
Yeah, can we pause the video? I need to get a tissue. What you see in the blood, when you take an AI, let's say your level is 45, and there are plenty of good doctors out there and plenty of people on Reddit that will be like, dude, you need to take, that's too high. When you lower your serum estradiol level from 45 to 25, let's say, still within the normal range, most guys wouldn't bat an eye at that. You have no idea what you've done at the tissue level. In fact, what we know, at least in certain tissues like bone, and especially in the vascular space, that you may have crushed it down to zero, or you may have crushed it down to single digits.
Right. Yeah, it's not necessarily linear, right? You don't know.
Exactly. The aromatase enzyme doesn't live in the blood. The aromatase enzyme lives within the cell itself. And that's where the AI acts. And so very small changes in serum estradiol levels can actually have very big effects at the tissue level. And we know this from studies where they've measured what's called flow-mediated dilatation in the arm. So they put a blood pressure cuff, like a tourniquet, on your arm, and they pump it up, and they leave it there, and they let your arm get ischemic, start turning blue. And then when guys can't take it anymore, they release the cuff, and the blood, perfuses the arm, and they have an ultrasound, and they're measuring the diameter of like the brachial artery. So if you have a healthy amount of nitric oxide, if you have healthy blood vessels, what you'll see is that artery just dilates, it balloons up really nicely. And it's a direct measure of the health of that blood vessel and the amount of like nitric oxide that's produced by those tissues. So there's a very good proxy actually for vascular disease. So if you test somebody and they have very poor flow-mediated dilatation, that's associated with higher risks of MI. It's associated actually very highly with erectile dysfunction. And so all these other like bad things that happen to your blood vessels. So some pretty cool studies where they gave healthy young men a single dose of anastrozole, just one dose, it was like a milligram of anastrozole, and they checked their flow-mediated dilatation, and it only dropped, surprisingly, their serum levels acutely by, it was like 5 points or something like that within this like first 24 hours. But there was like a 40%, I forget the exact number, it was a huge drop in flow-mediated dilatation, and it persisted for like 3 or 4 days, after If just one dose of an AI made a huge difference in the diameter and the ability. So it basically crushed their nitric oxide levels, which is one of the other benefits of estradiol. Yeah. So it really helps with nitric oxide production. So again, small changes in the serum oftentimes can mean big changes at the tissue level, and you will have no idea because there's no way for your doctor or for you to measure the estradiol levels in the tissue short of a biopsy. So, but this flow-mediated dilatation is kind of it's a proxy. It's sort of a roundabout way of measuring tissue effects. And the anastrozole had a huge effect in that. So if you want to continue to have erections into your 50s and 60s, you need estradiol. You need nitric oxide. And one of the best ways to get nitric oxide is to keep your estradiol levels nice and high.
Yeah, for
and
sure.
Your androgen levels, of course. They have to be together, right?
Yeah.
So
no, it's an excellent. I mean, anytime I'm talking health stuff with guys and they're on the fence about something, and you come back to, you come back to the penis talk, and you get their attention back real quick. So you start talking about anything that's good for your heart is good for your penis, and AIs are not good for your heart. They're like, hold on, what are we talking about now here? Like now you have my attention. So it's a great teaching point for sure. And there's also too, they think some of the. Because we talk about, or people talk about estradiol a lot too, but no one ever really talks about estrone. No one tests estrone, and there could be some negative effects there too. I was reading a bit about that, so that's interesting too. So it could be, you might even be checking the wrong thing in general.
You're checking the wrong thing in general.
There's so many.
Well, and the AIs also, that gets back to this, the testosterone is a prohormone, of course. And so, there are effects that testosterone itself has, but most of the effects of testosterone are from its downstream metabolites, which most people are familiar with DHT and E2. But that's just the beginning. Those are the first two. Each one of those gets metabolized, multiple metabolites. It's like a tree, with multiple branches that go downstream. And again, taking an AI or taking finasteride for that matter up high at the top of that cascade can have very unpredictable levels with the active metabolites that are 2, 3, 4 steps down the chain. And you have no way. These are not tests that are like readily available. You can't go down to Quest Labs and get some of these distal metabolites tested very easily. They're like, you have to go to an academic center. So, you're shooting blind. No, you're shooting blind. When you take an AI and you take finasteride, you're just shooting in the dark. You're shooting in the dark. And, I'll be honest, it's a sign of an inexperienced clinician, in my opinion, that routinely uses either one of those drugs. It's, a lot of haven't done your homework.
Guys get nervous about their hair too, so they want to take a DHT blocker, and that's great. So cool, your hair's there.
I get
but
it.
Now your penis doesn't work.
Right.
Yeah,
I get it. Yeah. Listen, if I could wave a magic wand and have the head of hair that I had at 35, I would do it. Of course, my wife would probably make me do it. But the fact of the matter is, like, if you have the gene for male pattern baldness, barring some major like genetic discovery here in the next few years, like, you're going to lose your hair, so can you delay it? Yeah, of course you can delay it, but by the time you're just in your 70s, guess what? You're going to be bald, or you're going to have to do you're going to have the comb over, that some people have. So
save your money for a trip to Turkey.
Embrace your fate. Yeah. Or you can, get there's nothing wrong with that. If guys want to go get a transplant, I get it. It wasn't for me.
Depends how you look. You have a good noggin there for bald. So
it's a big lumpy. I have a big lumpy. I'm 3% Neanderthal according to 23andMe. So
nice. It works.
But the fact of the matter is, like, listen, if you've got the gene, man, I'm sorry. Like, join the club. You're going to lose. You either lose it now or you lose it later. And it's not for me to say which is better. That's a personal decision.
Sure.
But it's like, again, barring some like CRISPR technology where we can rewrite your DNA, you're probably going to lose your hair.
Yeah, it might happen.
Yeah.
So what do you
ask? It could.
Do you get guys come to you when they're new and say, "Hey, where do you want my levels to be?" Do they ask you that question?
Yeah. Every now and then, for some reason less than I used to. I say, listen, I want your levels to be where you feel and function the best and where your health is as good as it possibly can be. That's where I want your levels, within reason.
Gotcha.
And with the caveat that, like, again, you're not going to convince me that you need a total T of 3,000 to feel good, right?
Yeah,
like
and I say something.
come on.
I tell them something similar too, and then I give them kind of my 20 to 40 nanogram spiel. But then I also throw in there too. I say, hey, but higher is not better. So I get a lot of guys. They don't want to be that high. Sometimes I'll say this, and people say, "Nah, you're crazy, man. Everyone wants higher." But I have a ton of guys.
No.
They're like, holy cow! I feel edgy. I'm not sleeping good. Can we lower the dose? And I want to go back to where we were last time. That was, we're running a little too hot here.
Yep.
That's
I've had guys who are prone to anxiety and panic attacks when on their own they upped their dose on their own, and they ended up in the ER with a panic attack. Again, that's those downstream metabolites, these neurosteroids, and they're very potent. They're very, very potent. And so you're absolutely right. More is not better. More is not better. Enough is better. Enough. The right amount is the right amount.
There was another clinic owner online. It was civil. We were chatting back and forth, and he was saying, "No, he's like basically zero of my guys are under 200 milligrams per week." I said, "Really?" So I'm really surprised by that.
I just don't see that. Yeah.
Yeah, it was very strange. He said, "Well, I have thousands of patients nationwide, and they're all over 200." Like, man, I don't know. Different demographic.
There's probably
I don't know what's happening there.
Confirmation bias too. Confirmation bias, that's a real thing. When you get this idea in your head and then you just fit everything to that idea. It's the same with estradiol. There's a lot of confirmation bias with estradiol. And people, are convinced that AIs work, and it's just not the case. So, I'm trying to think if I have anybody over I don't have anybody over 200 milligrams actually. I don't have a huge practice, but it's rarely necessary. It's a bell curve, right? So there are guys that need 250, but you start pushing above 250, and that's sort of where I'm rethinking my diagnosis. What am I missing? What am I missing here? If you're not better at that point, like, what have I missed? What's really going on? And oftentimes you find other things in their lifestyle.
Sure.
A big one is guys are closet. There's a lot of closet drinkers out there, and they don't reveal that. There's a lot of guys drink too much alcohol, and they don't even think they're drinking too much alcohol, but they are.
People will hold stuff back too. It's like
they do, of course.
It's like working in the ER. The fourth time you go in the room, they finally give you that key piece of information. Like, I didn't mention this thing about, I had an MI 5 years ago or something. Like, what? Like, you didn't think that was important to tell me?
Exactly.
Some guys, a couple visits in, they'll be like, I'm getting a DHT blocker from an online place, and I didn't mention that. Does that make it? I didn't think it mattered. Like, no, it all matters, man.
It all matters.
Tell me.
Well, it gets back to, you have to build up a level of trust with your patients. And you that starts on visit number one, but you don't get there all the way. Sometimes you have to get to know these guys, and it can be 6 months into that doctor-patient relationship where then you start finding out that their marriage is on the rocks, right. Their kid is in rehab, and they're having all these other issues, and that's playing a huge part into the why they're not feeling well, and they're stressed, and they're not guys are they don't want to reveal that to a stranger.
Oh, sure. It's tough.
So if you get to know them and over time you have a track record where you show that you genuinely care about them and you really do have their best interest. That's why I want my guys to know that I every decision that we make, like, I'm putting your best interests at heart. It's not my best interest. I'm trying to do. You're paying me to do what's best for you, and I genuinely do that. And once guys feel that, then they'll start to open up a little bit and talk to you, and you learn a lot. You learn a lot at that point. So, which is actually kind of another fun part of this kind of medicine too. You get to know your patients.
Oh yeah.
In the ER, I don't get to know my patients.
Text me from their vacation, like, hey man, we're at the
Me too.
We went to that restaurant you recommended. Here we are. Yep. Here's me and the wife. That's awesome.
Yeah, it's fun. It's really nice to have that. In my practice, yours is, I'm going to guess, is probably very similar. You end up collecting a whole group of guys that, like, I'm kind of like, I would probably you and I would probably hang out anyway. Like we would probably be buddies anyway, because we have a lot in common. So you end up attracting, people that are on the same page as you and have the same values and things like that. And it's those guys are
it makes for a
enjoyable.
nice date, right? You're having a bunch of chats
I have a
with
group
some
of
friends, and it's pretty
totally.
good.
It's just like these are people that I actually enjoy spending time with, as opposed to my emergency medicine practice. I would definitely.
It's
not
hard to
wanna
relate to the
spend
guy
time.
who smoked meth 10 minutes before.
The
he saw
guy
you.
coming down from the meth, his meth binge. He and I are probably not going to have a beer afterwards.
Probably not going to be friends on the outside.
We're not going to be friends. Yeah, probably not so much. But I've got a handful of physicians like that I take care of, and I really enjoy those interactions as well. So it's very, circling back to what we talked about in the beginning. It's a very rewarding field of medicine. So
It's awesome. It's awesome.
yeah, it's totally great. It's great. Yeah.
Yeah, I think we covered some good ground here. This has been great. I appreciate you.
Yeah, I've totally enjoyed it. Yeah, thanks for reaching out. I've followed some of your stuff online, and I've read like your answers on the forums are always like really well thought out.
Oh, thanks, man.
Sometimes I just write like these grumpy one-liners, but like you actually take the time to like explain things. I'm like, that's how it should be said. That's well done.
It could be a little bit of OCD or something too, because sometimes I'll start tapping something. I'm like, nah, it's I want to pull it back, or I want to put some a little more time into it, and it's it takes some extra time. But I hate seeing on there, and not that you do this, but I hate when you see someone give like a snappy answer to someone. Or something kind of like they're being kind of shitty with them, like
being snarky.
The guy doesn't know. He didn't read this whole, or they'll say, "Hey, go back and read the forum or look at the videos," or like, come on, give the guy a break. It's day
important
one.
to
Day one,
exactly.
you're hammering him.
Right. It's
You're gonna scare him away,
we've
he
been
goes
doing this
away
for 20 years. We've got 20 years of clinical experience with this stuff, and there are people like this is literally day one, and you have to hold their hand. And you know what? You're gonna have to have that estradiol talk one more time. For us, it's the 900th time. It's the 900th time, but it's the first time for him. So you have to be okay with that.
Oh yeah. And now we have peptides in the mix too. We get to talk about that over and over again.
Next, we'll do the next podcast on peptides.
Yeah, we should do it.
So I have some feelings about those too. So.